in the severe vertical bone defect of monoridge, severe, because we spoke that the advantage of this device is the space-making action. And so when we have to perform the GBR in a severe, in which we have to place a big quantity of biomaterial in a standing ridge, we can use this kind of barrier. Horizontal and vertical bone defect of medium level, not severe level, medium level, but extended in length. It means that we are regenerating the bone for 5, 6, 7 teeth. And so the customization of the mesh helped the surgeon in the definition of the correct spatiality of the regenerated bone. Then horizontal and vertical bone defect of medium or severe level, and now is standing in length, which regards the curved areas. Because with the software tools, we can model the volume with the curve, and then the printing with the laser technique, laser printing technique, they customize the meshes. Vertical and horizontal bone defect of level also medium, but that have to be treated in only one surgical phase. For example, a patient that has right and left. The patient comes from another country. I receive often patients that comes from other countries or other regions that cannot come in my practice a lot of times. And so with this procedure, with the using of customized titanium meshes, I can perform the GBR in very short time. And I can do here, where I want. 1 hour and 35, 40 minutes for each side. Vertical bone regeneration, 4 teeth, 5 days, teeth, in 1 hour and a half. And so, and then I can relax the patient, and after 10 minutes, start with the opposite side. And that severe atrophy of the complete upper jaw. This is the first case, posterior upper jaw. The patient has been operated for a tumor and a lot of quantity of bone destroyed. Removed the complete alveolar bone and severe horizontal contraction and vertical contraction. So we perform before the sinus floor elevation. Why? Because the defect involved both regions, the sinus and the ridge. This was the quantity of residual bone on the region and over the top of the sinus. So the first stage is the sinus floor elevation. I performed flat, I elevated the flat with a full thickness approach. I define the bone wall through the use of this surgery instrument. I removed the bone wall. I elevated the Snyderiana mucosa. Then I protected the Snyderiana mucosa with absorbable membrane. I grafted the inside of the stick bone. I placed the bone wall over the top of the biomaterial, fibrous membranes, and closure of the flaps with a double line of suture. Always, because the opening of this surgery is the main cause of failure of the sinus floor elevation. the opening of this suture, this wound. 6 months after the sinus, this was the regeneration of the bone inside the sinus, well compacted, and you can see that I placed distally and strategical implant. Strategical implant, because the patient missing lateral canine, first premolar, second premolar, first premolar, and first molar, second molar. 6 teeth. You cannot ask the patient to stay without the teeth. But you know that we cannot place over the top of regenerated area a mobile prosthesis. So you have to plan in order to guarantee to the patients a good quality of life, but at the same time to protect the integrity of your surgery. So now we speak relating PGR. We are excluding the GBR. A new paradigm, a new concept. With this device, you can perform the PGR, prosthetically guided regeneration. It is an evolution of the bone reconstruction. We don't perform the bone regeneration and then inside the bone where we manage to regenerate, we place the implant. No. Today we perform the virtual reconstruction of the prosthesis, the ideal profile of the prosthesis, the ideal length of the crown, the ideal three-dimensional spatiality of the crowns. And then we place the implants in relationship with the ideal virtual prosthesis. Naturally, in virtual way, because we don't have bone. But then, around the virtual implants, we can reconstruct the virtual bones. Everything is done with a laptop. Wonderful. With a laptop. And then on the virtual bone, we can treat with the laser melting technology, they customize the data meshes. And so, this is the ideal virtual prosthesis that is matched with the CBCT, for which we can place the implants in the ideal position. And you can see that the implants are placed not in relationship with the bone, but in relationship with the crown. I wanted to place the implants perfectly below the crown. Do you have bone or not? It's the same. And then around the virtual implants, we can reconstruct the virtual bone volume. I left the implants in evidence inside of the bone volume because I wanted to show you, is a demonstration, I wanted to show you how the regeneration of the bone is in harmonic way around the implants. But normally the bone volume, the virtual bone volume, is on the heads of the implants. And then on this bone volume, STL file, we can print the customized data. Just this memory is the future new that I will introduce a customized titanium meshes with the grafting window. It will be the main new that I introduce that allows the surgeon to place the custom without the biomaterial. Normally, the custom has to be filled in the container and then placed over the top of the defect and fixed with the screws. Instead, this container, this custom that is made from two pieces, one the external container, and then the cover that closes the grafting window from which we can graft the biomaterial. And this is a great advantage because we can fix the membrane, the mesh, without biomaterial. We don't create any risk of pollution of the biomaterial. Then we can place the mesh without biomaterial and then we can control the position of the mesh. But if you have the biomaterial, you don't manage. And then we can calculate perfectly the quantity of biomaterial. Because if you have to fill the custom before, you don't know which is the quantity, the ideal quantity. Instead, placing the container, grafting the biomaterial, you can place the ideal quantity of biomaterial. But there is another important thing, that after the fixation of the custom, you can wash the titanium mesh. Because during the fixation of the custom, you touch the mesh, pollution of the mesh. But if you should have the graft inside, you cannot wash it, you cannot decontaminate, you cannot use the chlorhexidine, you cannot use the physiological solution, because there is the biomaterial. Instead, if you have the container that is free, empty, when you fix the container, wash, clean, graft, cover, wonderful. And so this is the case, surgical case, as the extension of the design of the flap, distal release incision, mesial release incision, paracrestal incision, preservation of the papilla. This is the container. The container is placed over the top of the head. And look at, I place and I fix the mesh, not perfectly. You can see that near the bone peak is lightly open. But you can see that in next picture, this gap, there isn't. Why? I remove a screw, I place better, and I engage the screws. Because this action can be done when you don't have biomaterial inside. When I finish to fix the custom, I noted that there was this problem. I changed the position. But in this way, you can control the fitting between the border and the residual bone. Wow! You can work in the defect perfect. the biomaterial is calculated according to the needs. Step by step, place the biomaterial, step by step, and then fill perfectly. And when I finish the cover, voila, the cover. You don't need to block the cover, because the cover has a special engagement for which you don't need to fix with something else. You push, and pushing, it remains blocked. And then, naturally, we protect it with absorbable membrane. We close with a double line of sutures, and look at, in the corner, I activated the implants that I placed 5 or 6 months before, at the time of the sinus floor elevation. This is a strategical implant in order to support the prosthesis, quality of life. I say always, I have to distinguish myself from the hospital. If you should receive a treatment like this in the hospital, probably in the hospital the surgeon take a bone here in another place, and then say to the patient, you cannot place anything. I wanted to create a different modality of working. The hospital sent me the patient, because I create the condition in order to offer quality of life, not only concentrated in GBR or PGR. Suturing and the healing of the soft tissues. Now, I will take any pressure in order to organize with a locator the mobile prosthesis with the implant support. A very simple prosthesis. But the patient has the teeth, temporary teeth, without any risk to damage the site regenerated. And you can see that there is a gap between the prosthesis and the top of the ridge. Bone. Bone. Wow. This was the bone near the sinus. This is the three-dimensional bone regeneration. But it's very incredible. The sobreposition of the project, implant project, with which I define the virtual volume and the real volume. I prepare again the project, the implant project, and these are the implants placed inside the bone, the regenerated bone. But look at the relationship with the implants, the position of the implants with which I define the bone volume and the effective position of the implants. Fantastic. We have the perfect specularity of the position of the implants. So this is the time of the second stage. I open the flap, I remove the cover, and voila, very simple. And this is the bone, well vascularized. Do you remember the bone that I showed with the non-absorbable the reinforced membrane. Sometimes the quality and the vascularization was perfect because we hadn't an adequate vascular support. Instead, here we have a microporosity from which the vessels can involve the regenerated area. I remove, look at which is the quality of this bone. Red, well vascularized. We define perfectly the curve of the ridge. Place the implant inside in the middle of the bone and close again the soft tissues. Waiting for the healing. And this is the comparison between three different stages. The virtual project without bone, the virtual project with the bone, and the implants inside the bone. Look at which is the precise sobreposition of the position of the implants. And which kind of bone and quality of bone we have buccally and around the implants. A good quantity of bone, a quality of bone. Now we have to activate the implants. We don't have a keratinized tissue band. We have the frenulum on top of the ridge. We have lost the depth of the fornix. We perform a crestal incision from the mucogingival line. We move the alveolar mucosa apically. We activate the implants, anchorate the alveolar mucosa with the absorbable sutures. And then I harvested a graft of keratinized tissue band on the palatal area, placed around the implants, stabilized with several compressive crossed sutures that protects the palatal area, maintaining in the position, in the correct position, the collagen material, and then pressing the free gingival graft against the vascular bed. This is the profile of the bone. 10 days later, wow! The complete integration of the graft. No necrosis. Enormous quantity of tissues, no necrosis. The secret isn't the thickness of the graft. The secret is the modality of adhesion between the graft and the vascular bed. And you can see how many sutures I gave in order to stabilize and create a perfect fitting between the vascular bed and the graft. If you don't perform this kind of compressive sutures, the risk is the formation of an hematoma in the gap between graft and vascular bed. And the hematoma can be absorbed, of course, but the time of revascularization of the graft is longer. Because before the hematoma has to be absorbed, then finally the vessel can arrive and involve the graft. And in the meantime, the graft goes in necrosis. So, good quality. And we restore perfectly the missing bone. Adequate proportion, restoring the depth of the forearm, arch, that I restore place the position of the implants correctly below the crowns, not in the palatal zone with the cantilever outside in order to place the crown in arch. The new paradigm of the bone generation. PGR with the customized titanium mesh of new generation. Another case, posterior lower jaw. So I would like to ask and think. I am looking at the auditorium is full. And for me it's a great pleasure because it's the 4 p.m. From this morning you are with the patient here in me. And so, can I take a pictures with you? You, it's incredible, this picture. Bye-bye. It's incredible. Thank you. It's very strange at this time, Sunday afternoon, that the auditorium is full. So for me, it's exciting. Thank you so much for your presence. Thank you. So, posterior lower jaw, initial CBCT, a very severe bone defect, long defect, extended defect. This one with a non-absorbable titanium reinforced membrane would be very difficult because probably we should place two membranes, adapt two membranes, and we cannot control the spatiality of the bone. Instead, in this way, we define perfectly where we want the bone volume. So, this is the scans, the prosthetic digital project, the relationship between the prosthetic project and the residual bone, placing naturally in a virtual way the implants. Then we define a volume, the bone volume, as a container of our virtual implants, and then we started with the GBR. A very severe bone defect, the presence of the ventral nerve over the top of the region, the malleoid muscle insertion in the malleoid line. It means that our absorption, our defect is very severe. And then another limitation, the residual cortical bone that is very thick, no cancellous bone, no vascularization. You can see that all perforation that I perform, no bleeding. So, very critical condition. But this is our custom. Wow. In 1 second, you can place that. Perfect, precise, precisions. It's incredible. And so, custom plus membrane. Results. Ooh. And look at the fitting between the border of the mesh against the bone, which is the precision between the border of the mesh and the bone, and inside the complete regenerated bone. And so, when you remove the mesh, wow! The shape of the new regenerated region is identical to the shape of the container that we planned, relating the virtual prosthesis, relating the virtual implant. And so, now, with a surgical guide, we can place our implants. And after 3 months, this is the quality of bone. Why? Do you remember? We spoke. I remove the mesh, I place the periosteum in contact with the bone, and this is the maturation of the bone. If we analyze the difference, okay, look at which is the difference. This is radio transparent. 3 months later, this is the density. Wow. So now it is the time to manage, to uncover the implants, manage the soft tissues. And so I elevated a healthy flap. I moved the mucosa apically. I have activated the implants, harvested with a template the gingival graft, placed around the implants, and well stabilized with several compressive sutures. Wow! Restoring of the depth of the fornix. New bone volume. The vertical bone regeneration can exist. Another case, anterior upper jaw. It is a disaster. This young lady received a kick with a hockey. But I don't know the name in English. Okay, instrument. Okay, here, from his husband. Destroyed the face. And I received this case from Milan hospital. They restored the face. Orbital bone, nasal bone, frontal bone, everything that they could. And then, in consideration of our collaboration, they asked me, Marco, can you come us to solve this problem? Yes, it's my job. It's a great pleasure. And so, this was the contraction of the bone. A disaster. The question is, can we reconstruct the regenerated, this type of defect with the regeneration of the bone? So, this first step is the same that I propose with the using of customized titanium mesh. The PGR, prosthetically guided regeneration. So we define the length of the crown, we place the implant, and we reconstruct with the virtual project the bone around the implants. And we obtain with the laser melting technology the customized titanium meshes. So, the surgical stage, I elevated a big flap, and I detached the palatal flap and the buccal flap, placed in evidence the residual bone, facilitated the flaps, harvested the bone, filled the container or the castle with a mix between 50% of autogenous bone, and 50% of cancellous, xenograph material. And then naturally I close and flex vertebrally over the top of the ridge. The good healing depends on the primary closure of the flex. And so I waited 10 months, I don't remember. And then this is the day of the removal of the mesh. Wow. Wow. I can say wow for me, not for you, for me. Because each time that I look at this case or other cases, similar cases, I am impressed. Because until some years ago, I didn't have any possibility to reconstruct in this way this quality of bone. The introduction of this device is changing completely the paradigm of the bone generation. Enormous and confirmed bone regenerated bone in curve in relationship with the prosthesis. I place for implants, I close the flaps, maturation of the bone with the periosseum contact. The day of activation of the bone, but look at which is the consistence of the bone that there is below the periosseum. I didn't have any absorption. Oh my God, now stop. And I moved the alveolar was apically, but the quantity, I don't know if I can show you, but in any case, here in the palatal area, probably I have a picture that I can show you a little detail. In the yeah, probably it is here. Okay. Okay. Here you can see that in the middle of the palatal area there is an enormous torus. And this enormous torus was a limitation in the grafting of the tissues for the anterior zone. And so I decided, considering that I needed a bigger quantity of tissues in order to cover and to protect the site around the implants, I decided to take the tissue. It wasn't the first case, but in that precise case, I decided to take the tissue from the skin in the retroclavicular area. I define which is the jugular venous, where I have to place or take my tissue, harvesting and long quota of tissues, and closing for the first intention. Big advantages for the patient, because the patient don't suffer. The closure of the flaps are for the first intention, not for the second intention in the palatal area. And so I place around the implants this quota of tissue harvested on the retroclavicular area. And this is the quality of tissue after 1 week. But look at the fornix, and are you curious to see how this tissue is transformed? Is it similar to the keratinized tissue band or not? Wow. It's the same. Harvesting skin, the harvesting of the skin is a less dangerous procedure. We don't have vessels as in the palatal area, and reduces the morbidity for the patient. We have the primary closure of the wound, and we don't have to wait for the second intention healing as in the palatal zone. And then, if we harvest a very thin layer, we have the complete transformation of these tissues in keratinized tissue band. So this was the case before, and this is the generation of the bone. And you can see that the placing of the implants are perfectly in the middle of the crown, because the bone volume has been determined from the virtual implants, conditioning from the virtual prosthesis. And you can see that I added a portion of the resin in order to cover the gap between the length of the crown and the profile of the gum. Why? Is it an unsuccess? No, because I didn't perform any surgical procedure relating the reconstruction of the patella. I knew that this was the final result, but the final result is justified because the patient, when smile, don't expose. And I protected the patient from an invasive new surgery relating the increasing of vertical bone, the increasing of the vertical soft tissues. Which is the time? Okay, I show this case and then I would like to jump in a case in which I perform the reconstruction of the papilla, in which after the GBR and the soft tissue management relating the restoring of the depth of the fornix and the increasing of keratinized tissue band, we have to perform also another surgery relating the vertical increasing of the crystal soft tissue in order to determine the shape of the papillas. Another case, traumatic accident, lost the bone, placed the implants, lost the bone around the implants, removed the implants, waited for the healing, and the floor of the mouth is on the same line of the floor, the top of the ridge. So I waited for the healing. You know, someone of you attended the course the previous day, and I underline that we have to work always with a good quality of tissue. and which is the time needed for the getting of good quality tissue? 3 months. I waited 3 months, and this was a defect. Oh my God, but taking the CPCT in order to perform the project, prosthetical project, implant virtual project, bone volume project, I noted that one of the teeth that I wanted to conserve was hopeless. And so we can see the absorption of the bone, that clinically it doesn't appear, but radiologically, yes. And so I removed the tooth and I waited other 3 months. And so after 3 months, oh my God, finally, the quality of tissue is good. The residual bone peaks are well represented. Now we can perform the virtual project. This is the defect, and this is the virtual prosthetical project. Then we place the implants in relationship with the virtual prosthetical project. 41, 3.3, and then our fantastic virtual bone volume. Bone volume with the curve, with the horizontality, with the verticality, everything can be calculated in a very easy way with the tools, software tools. You can play with your bone volume while you are watching the TV in the cinema. Do you know cinema? The player, the tennis player, #1 in the world, now #2. So we reconstructed the bone volume. Wow, well defined, and this is the new customized titanium meshes that we personalized for this type of defect. Design of the flap, 2 teeth involved laterally, preservation of the papilla on both sides, crystal incision, and 2 vertical release incisions with a stick OK design. A big grafting of autogenous bone. Well, here I wanted to reduce the thickness of cortical layer. I wanted to stimulate the bleeding. And so, where I have to harvest the bone? Here. And so I mix with the biomaterial, perforated the bone, passivated the buccal and the lingual flap, filled the container, and placed the container over the top of the ridge. Only 2 screws. It is such precise that probably you could leave the device without the screws. But normally I place always at least 2 screws on the buccal side. I close with absorbable membrane, protected with absorbable membrane, and suture. We managed to close. Why? A good passivation of the flaps, but also a good strategies of the design of the flap and timing of the suturing. And this is the healing. Then, after 10 months, open the flaps. This was the bone defect repair, in which we placed virtually the implants, reconstructing completely the missing bone, and then open the flaps, open the mesh with a cracker line, bone, bone, and well curved bone. How the natural normally contain the teeth in the curved area. And so, big bone. I placed a special guide in order to harvest the bone, because it is my job to understand the behavior of the bone, the quality of bone, and so I perform always histologies in order to understand which is the ideal scenarios. And so I use a different guide for the harvesting of the bone from the guide that I used for insertion of the implants. 3 implants, well placed, closure of the flap, maturation of the bone, and then activation of the implants, moving of the mucosa apically, bone, in maturation but bone. And so, harvesting the tissue of the skin, because a big piece, very big piece, design with a template. I define the dimension of the tissue that I have to harvest, and then create this pointed or tipping final design of the template in order to close perfectly the skin. I remove a very thin layer, I suture with the plastic, I close with the plastic sutures, and I place against the healing abutment. Healing abutment lingually, crystally, and buccal. We added 8 sets of keratinized tissue band. We lost completely the depth of the fullness of the lingual and the buccal. My God, after 1 week, the tissue is in transformation. And then, waiting, it is more mature, and we completed the procedure. Where there were 14 millimeters in verticality of defect, we covered the defect completely. I believe that I don't manage to show you this case, because I would like to show you I can show you the X-ray in order to understand what does mean the bone regeneration. This is the comparison between the virtual project and the regeneration of the bone. We planned for the virtual project 11, 13, 13, 13, 11, 13, 13, 13. We placed 11, 11, 13, 13, 13, 13, 13, 13. Oh, sorry. I showed some cases without papilla, because we didn't need the papilla. The reconstruction of the papilla would be an over-treatment for the patient. The soft tissue management is important in order to guarantee a stable seal around the implants, in order to guarantee the prognosis of the implants. But if we wanted to reconstruct the papilla, we need to satisfy, it means that we need to satisfy the aesthetical aspect of the reconstruction of the bone that we are performing. And when we have to treat a case like this, in which traumatic accident determine the losing of the multiple teeth, we lose always the interdental big bone. And the interdental big bone is the support for the papilla. It means that if we are lucky after the losing of the teeth, the ridge is flat, if we are lucky. Differently, the profile of the ridge is concave. And sometimes we have sufficient bone in order to place the implants, but we are not able to satisfy the aesthetical request or needs of the patient. And so now I present a different protocol that I perform when I have to satisfy both clinical and aesthetical expectations. So we have to place the tip of the papilla at this level. If we are not able to place the tip of the papilla at this level, under the aesthetical point of view, we fail. Differently, we can compensate the missing of the papilla with the porcelain, pink porcelain or other material. But we didn't manage to restore the missing teeth satisfactory, both aesthetical and clinical aspects. Different aspect and different difficulty is when we have to substitute only one tooth. It is true that we are working the anterior zone. But as you can see, when I have to remove the tooth 1.1 or 11, I don't know which is the nomenclature in Vietnam, we can see that we have a well-represented papilla on the right and on the left. And the scallop of the gum is placed on average on the same level of the adjacent tooth. It means that it is true that I have to substitute this tooth, but I don't have to reconstruct anything. I have to maintain what it is already present, papilla and scallop. Probably my job is concentrated in the conserving of the bone, socket preservation, socket regeneration. But I am starting with the ideal profile of the gum around the tooth that I have to substitute. And if I perform correctly the surgical procedure, we could say that this type of surgical treatment is very easy. Very easy. And another case, papilla well represented, scallop symmetry to the adjacent tooth. After a lot of years, everything has been maintained perfectly. Papilla and scallop, papilla and scallop, papilla and scallop, papilla and scallop. Papilla and scallop. Papilla and scallop. I could show a lot of cases. Papilla and scallop. Papilla and scallop. It's very easy because I started with the presence of papilla and scallop. Different aspect when we lost one parameter. We have papillas, we don't have scallop. And so, the surgical procedures is changing. Not in order to reconstruct the papilla, but in order to move the scallop on the ideal line. Probably this could be considered more complicated of previous. But when we have to substitute more teeth, as I presented before, we have to reconstruct papilla and scallops. We lost everything. We lost several teeth, absorption of the bone, traumatic absorption of the bone, contraction of the gum. And so I prepared this schema that will be published in the next article, in which I divided 3 different therapeutic difficulties. Significant exposure of modest bone defect during smiling. Significant exposure of medium bone defect during smiling. And significant exposure of severe bone defect during smiling. And then I evaluated 3 statistical results. The chromatic tissue integration, the inter-implant papilla, and the proportion and symmetry, the prosthetic elements. And then for each one, I have 3 different levels of statistical results. For example, inter-implant papilla, scars, barely present, or present but not aligned ideally with the natural papilla, or present, well represented, well structured, and with ideal verticality. So each one determines a point, a score. It's normal that the ideal score has to be 9. And when we manage to perform the case number 3 with the score 9, it means that we perform a very strong surgical procedure. Everything has been done perfectly. And so this article will be published next week. Now has been submitted. And I don't have more time. I could show you a case for each one of this scenario, but I want to present, oh my God, only one case. This one. Probably two cases, I don't know. This one. Traumatic accident. I tried to run. Traumatic accident. Partial absorption of the papilla on the lateral incisor and losing of periodontal attachment. A critical condition for GBR. We place this case in terms of difficulty score in case number 2. Partial vertical bone defect and horizontal defect. Not a severe vertical defect. Partial. Number 2. We perform a vertical bone regeneration with the non-absorbable titanium reinforced membrane. This is the results. Why I am starting from the results? Because I wanted to describe the rationale of the treatment that I am proposing. The rationale. Okay? This is the sovrapposition of the tooth, lateral incisor, that I captured during the surgery, in which there is the bone. And you can see that 3 millimeters of the root over the top of the J is uncovered from the bone. Is the space for the periodontal attachment. Okay? I move this anatomical spatiality on the lateral incisor in order that now we know that there probably there is the bone. Then on the red line there is the chain, and 1 millimeter below the chain there is the free gingival margin, 1 millimeter. It means that from the free gingival margin to the bone, normally we have 4 millimeters, the periodontal environment. Now I move this spatial anatomy on the central incisor. If we wanted to get aesthetical results, the central incisor are longer 1 millimeter more the lateral incisor. And so I place 1 millimeter here, the free gingival margin, 1 millimeter higher than the lateral incisor. The free gingival graft and the place where we wanted to have the bone. So, studying the spatiality of the anatomical structure around the implants, around the teeth, we can define why we have to place the heads of the implants and where we have to regenerate the bone. We cannot regenerate the bone random. It's not only a container in order to place the implants, but we have to regenerate the bone with the correct spatiality if we want to restore the missing papilla. And look at, from the heads of the implants, place to 4 millimeters from the free gingival margin and 3 millimeters from chain of our crown, we can measure other 5 millimeters from the tangent between the scallops of the central incisor and the tip of the papilla. And the natural papilla between two teeth measures 5 millimeters. But look at this detail. If we wanted to restore this type of papilla, we need 9 millimeters of soft tissues. And I am respecting the biology. I am respecting the periodontal width. So, how can we obtain this bone regeneration and reconstruction of the papilla? We perform the virtual prosthesis project because we have to define which is the length of our crown. And then in relationship with the length of the crown, we define where we have to place the implants. And with the CBCT relating the virtual crown, we can define the position, the spatial position of the implants and the distance between them. And then we know which is the quantity of bone that we have to regenerate in horizontally and in vertical way. So I perform an vertical and horizontal bone regeneration with the non-absorbable titanium reinforced membrane. I grafted the biomaterial mixed with the autogenous bone in order to compensate, do you remember, to compensate the remodeling of the bone after the removal of the membrane. And I am measuring the quantity of bone because I know which is the contraction of the bone. But I know also which is the quantity of bone that I want to maintain around the implants. I close the membrane, I close the flaps. Probably this is a very difficult aspect, the passivation of only one flap and the introduction of the buccal flap inside of the space between the teeth in order to reach the palatal flap. Healing, always healing. And so from here we got this regeneration and good volume that is adequate in order to place the implants according to our project. And now I elevated our thickness, full thickness flap, use the surgical guide in order to place perfectly the implants, perform 2 osteotomies, and this is the first piece of news in the new planning for the reconstruction of the papilla. The distance between the implants. Not 3 millimeters, 3 millimeters and a half, as proposed or published by Dennis Tarnow, Salama Brothers, but 5 millimeters. Why? I will describe the reason at the end, but 5 millimeters between them. I place the implants 5 millimeters between them. And then I grafted the connective tissue. You remember probably in the previous cases, I never grafted the connective tissue. And I didn't obtain papilla. I grafted a free gingival graft in order to increase the missing keratinized tissue band, but it's another field. If we wanted to treat an aesthetical case, we have to perform 2 different soft tissue management. One, in order to restore the depth of the forehead, increasing the missing keratinized tissue band. A second, in order to increase the verticality of the tissues. And so, we close perfectly the flaps, good quality flaps, but mucogingival line placed on the crestal side. And so, which kind of treatment is it indicated in order to increase the keratinized tissue band and to have a very good chromatic integration of our graft. I showed two different options. My personal cases, my failures, or unsatisfactory results. But I changed my protocol step by step. I tried. And so, on the left, classic case of free gingival graft covering the area in which there was the missing keratinized tissue band. Only that. And instead, on the right, the using of substituted tissue, mucograft. The results are this one. On the right, I managed to regenerate the papilla, but the chromatic aspect is unsatisfactory. Because there is the classic stamp effect, in which the chromatic aspect of the tissue harvested from the palatal zone is wider than the residual keratinized tissue band. Instead, with tissue substitute, we got a good chromatic aspect, but we didn't manage to get the papilla. Why? Because the healing is according to second intention. And the second intention healing offers a very thin layer of keratinized tissue that is not sufficient in order to cover the needs in millimeters of the verticality of the papilla. So, good chroma on the right, but no papilla. Good papilla on the left, but bad chroma. Oh my God. It means that if we want the papilla, we need to graft the free gingival graft. But we have to find the solution. We have to find the solution in order to mimetize the chroma. And the solution is this. And I have to consider that there is a high morbidity, but try to imagine a young lady that has in front of her the life, and she wants to smile free, without conditioning. And so probably this surgery is accepted. Because when you show them to the patients the results, they say, I want this one. So, but this one needs a more invasive surgery. Don't worry, I want this one. I wanted to smile again. Not all patients needs this kind of procedure, but this is an opportunity for selected patients. And so I desepithelize the residual keratinized tissue band on the lateral and canine side. Because the problem is not the color of the free gingival graft. The problem is the difference of color between the gingival graft, the free gingival graft, and the residual keratinized tissue band. And so for this, I remove the residual keratinized tissue band, desepithelializing and placing over them a big free gingival graft. So I place collagen material and substitute tissue in the upper jaw, sutured with a compressive suture, and this is the iliac. Then I activated the implants. I started with the shaping of the crown, step by step, increasing the composite and modifying the profile of the crown and create an harmonic profile of the gum, and now we can appreciate the presence of the papilla. I left the space between them because I know that the inter-implant tissue will ingrow. Why will ingrow? And then, do you need to have the growing of the tissue or not? We need that the growing of the tissues cover the last missing 2 millimeters. Why? Because the thickness of the flap that we have over the bone is normally 3 millimeters. The thickness of the connective tissue is other 3 millimeters, 3 millimeters and half. Complexly 6-7 millimeters. But you remember that we need 9 millimeters. And where we can get the last 2 millimeters? Do you remember the distance between the implants? And this is the secret. Placing the connective tissue over the top of such a large quota of bone, the good vascularization of the connective tissue allows it to engross and to cover the residual 2 millimeters. Instead, step by step, it covers. Move, move, move. Good quantity, good papilla, good shape of the scallops. And so we can see a good protection of the implants on one side, on the other side, good protection. And all parameters of the aesthetical results were respected. The papilla are all on the same line. The parabola on the central sides are symmetrical and placed 1 millimeter more apically than the lateral side, as our project. So I could say other cases, but I don't have time, more complex of this one, but I wanted to present this case because there was the rationale relating the new protocol for the bone, for the treatment of the aesthetical cases. I complete my presentation after this long day, sharing is my contact. If you would like to receive the papers relating the passivation of the flaps, lingual and buccal, you can send an email and my secretary will send you both papers. If you would like to have information relating the didactic activity, you can send me an email or visit my website. And the last one, information. I know that someone of you have already this book. I just finished to translate this book, very, very fantastic book. I can say, I'm sure that I am saying something that is the truth. And if someone of you would like to have this book, can speak with Vietnam company, because we want to organize the shipping of this book from the Italy to the Vietnam. And through the Vietnam company, you can receive this book. And so, or write me, or write to the company. I thank you a lot. It's been a great pleasure to share time with this fantastic audience. Thank you so much to stay here until now, and I hope to see next year also, always in Vietnam. Thank you. Bye bye.
Xin được cảm ơn rất nhiều phần trình bày của bác sĩ Macaronda trong buổi chiều ngày hôm nay. Mặc dù còn rất nhiều điều muốn nói nhưng mà thời lượng không cho phép. Và thầy Macaronda muốn chụp hình chung với lại tất cả giáo viên với một tấm hình giống như concept xét mà ngày hôm qua chúng ta đã chụp hình. So I would like to invite Macaronda. You stay here and take a picture with all the doctors. Yes. Và xin được yes, stay here. Yes.
Stay here.
Yeah. Dạ, xin được mời thầy Phạm Hoài Nam. Dạ, xin được mời anh Phạm Văn Hùng. Xin được mời Mr. Nicholas from SAC Plan, Mr. Oscar from Bracestep, and Mr. Darren from FDI. Yeah, please come to the stage and take a picture with Dr. Ronda.
Yeah.
Only you first. Yeah. Các anh chị ơi, chắc là thầy biết thả tim thì chúng ta cùng thả tim với thầy luôn nha. Thả tim.
Okay. One second. It's good? Okay. With the one or two fingers? Two? One. Two no more than one? Okay, one. Okay. It's true.
Dạ, xin được mời thầy Phạm Hoài Nam. Dạ, xin mời anh Phạm Văn Hùng. Và xin được mời Mr. Nicholas, Mr. Oscar, and Mr. Darren come to the stage and take a picture with Dr. Ronda. Dạ, các bác sĩ ơi, chắc là xin mời bác sĩ chúng ta đứng lên để cùng chụp chung tấm hình luôn ạ. Dạ, tấm hình đầu tiên chắc là xin tất cả bác sĩ chúng ta cùng like đúng không ạ? Like. Dạ, mình giơ like cao lên được không ạ? Khép vào người để che mặt người sau. Xin một tấm hình nữa là mình cùng giơ tay để chào, giơ tay để chào.